So hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the BioSkills of the Northeast Studio in Fall River, Mass. Today we'll be discussing Inspire with Dr. Ameer Shah. Before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Also, Duncan Hearing Healthcare. Hearing healthcare you can trust with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review. 5-star reviews are greatly appreciated. So now we are going to turn over to Dr. Ameer Shah, and we can start by, can you tell us a little bit about yourself?
Sure. Well, I first want to thank you so much for having me on today. As you said, my name's Ameer Shah. I'm a otolaryngologist based out of the Taunton area. My practice is ENT specialist. We have a few offices in Brockton, Taunton, Plainville, and Norwood. I grew up in the Boston area. I grew up on the South Shore in Braintree, and I was excited to practice kind of where I grew up. I did most of my training in medical school in Boston at Tufts, which was not too far away, but kind of nice to come back in this area and take care of the community that I grew up in. My clinical interests are kind of broad in the field of otolaryngology, or as people call it, ENT, ear, nose, and throat.
Yes.
I practice kind of the broad range in terms of adult and pediatric care, but my kind of clinical focus and interests have been in head and neck cancer surgery, as well as sleep apnea surgery, which kind of lends itself to today's discussion about the Inspire implant.
So now we're going to be talking about sleep apnea, obstructive sleep apnea. Can you kind of give our audience an operative definition, if you will, just like what that is?
So, a large portion of the population snores. Snoring does not necessarily mean sleep apnea. Sleep apnea really means that you stop breathing for short periods of time during your sleep. Kind of from a medical definition standpoint, we have to correlate a duration of that pause in breathing with a drop in your oxygen levels that are measurable in your blood. And that is what's defined as an apnea. And so people can have varying severities of sleep apnea in terms of how low their oxygen goes during the night, as well as how many times they stop breathing at night.
Right.
So someone who snores doesn't necessarily have sleep apnea, but usually someone who has sleep apnea snores. So we see a lot of patients coming in for snoring evaluations, and we're evaluating them for sleep apnea. And why is it important? Actually, you can put up some slides if you'd like.
Yeah, that'd be great.
So let's put this here. Okay, is that coming through okay?
Yeah, it looks great.
All right, so we said sleep apnea is kind of a pause in breathing with an associated drop in this oxygen saturation. In the United States, pretty common amongst the population, 10 to 15% of US females, and almost double the prevalence in US males. And what we said is, the severity of it. How bad is it? How many times do you stop breathing? How low does your oxygen go? And you can tell that on a sleep study. So you can either do that in a hospital setting, or now we're more commonly doing that at home, where you hook up a few monitors and then it's going to give us a number as to how bad is it. And that's called the hypopnea index, our apnea hypopnea index. And the number is kind of graded from normal to mild to moderate and severe. And that kind of can correlate with what are the risks of untreated sleep apnea. So aside from just feeling tired, what happens if you don't treat sleep apnea? And, we have studies that show that untreated sleep apnea leads to higher rates of high blood pressure, heart attack, stroke, abnormal heart rhythms, decline in cognitive function. You can imagine if you're not sleeping well, you just can't think right.
Right.
Harder to control diabetes, um, depression, insomnia kind of interplays with sleep apnea. And so, we see a lot of kind of downstream medical problems that not always caused by untreated sleep apnea, but often make it harder to treat those conditions. So that's why we care about it. And that's why it's important, more so than just you feeling tired. There's medical benefit. And, we also worry about people, say, driving a car when they're tired and operating heavy machinery and things
Absolutely.
like that.
Doctor, is there a correlation between the rising obesity rates in the nation and sleep apnea?
Absolutely. So there was a study that came out in the fall of last year called the Surmount OSA trial. And they were looking at, if you've seen in the news, there's these new medications called Wegovy and Ozempic
Yes.
that have come out. They're originally for diabetes, and we've seen a lot of improvement in people's weight as a kind of side corollary. And there was a medication that came out in the fall that worked in a similar way, that they actually studied people's sleep apnea numbers as it correlated to weight loss. And they saw a significant reduction in people's AHI numbers, or sleep apnea severity, as their weight dropped as well. So we've always kind of known that it was a strong corollary, but this was a large study that really looked at weight loss and the impact on those numbers.
That's a great study. How interesting is that? Now you have everything to back that too. So how hard is it to go do the sleep studies? I've heard that you can do those at home. Is that something like...
Yeah, they're pretty easy. One of kind of the good things that came out of the COVID pandemic was how much easier it made sleep studies. It used to be pre-pandemic, we would order a sleep study for a patient and insurance was kind of always asking us to do it in a sleep lab, which for some patients might be an issue with travel. Some people just don't sleep as well outside of their home environment. And so when the pandemic hit, we had switched to doing them at home for safety reasons. And now that has become kind of the standard, that most insurance plans ask us to do it at home first. And then if, there's any issues with the results or coordinating that, we can do it in the lab. So in general, they're very easy to get done.
So now someone has a feeling that they probably have sleep apnea. They go, they have this conversation with their primary. They get a referral from their primary?
Exactly. So I've seen it kind of go both ways, where some patients, their primary will work them up. But a lot of times they get sent to us. The primary care will be like, hey, you're snoring, or there's a concern for sleep apnea. Let's get you over to an ENT and have them kind of evaluate you and do the workup and kind of figure out, what the next steps are.
Now, suppose this is me. So I've done that. I have the referral. I'm walking into your office. Like, what do you do with me? Like, what are you looking at? And
yeah, so we're trying to tease out, okay, are you snoring, or do you have signs and symptoms that are concerning for sleep apnea? And we can often get that just from talking to the patient about, what are your symptoms? What are your concerns? How do you feel in the morning? How do you feel during the day? Do you feel like you have to take a nap to get through your day? Would you fall asleep in a dark room or in a meeting at work? Sometimes things like headaches in the morning are a symptom of sleep apnea. So we have a set of questions where we can kind of tease that out for a patient. Part of what we do is we also want to do an exam and do an upper airway exam. And that involves kind of looking at your mouth, your throat, the size of your neck, the shape of your body. And also sometimes what we'll do is we'll look with a small camera in the nose to take a look at the nasal anatomy, take a look at your airway, your throat, your tonsils, and see, is there points of obstruction that can be contributing not only to snoring, but airway collapse, where we think, hey, that might be what's causing your sleep apnea. Because that's sleep apnea is due to some reason why you stop breathing. It's either your brain is not telling you to take a breath, That's called a central apnea.
Okay.
And there's obstructive apnea where you're breathing, you're trying to breathe, but your airway is closed for some reason.
So sometimes, you'll see these infomercials, if you will, like use these strips. You won't have any more sleep apnea, like those little Band-Aids that go over the nose. Or, here's this great pillow. It's great for sleep apnea, or just sleep on your side, or buy this bed that inclines.
Absolutely.
What is that? Do any of those work or not with true obstructive sleep apnea?
So, for example, the nasal strips for nasal obstruction, those can be really helpful to help you breathe better. They can help with snoring, but they're not going to stop you from having those pauses in breathing. Now, maybe they can help reduce the severity, but they're not truly going to like stop a pause in breathing. We call it like recumbent sleeping or sleeping on your side versus supine or on your back. Certainly it can make a difference. A lot of patients will say, hey, if I have a pillow that's kind of pushing my neck up, yeah, it's going to kind of flex your neck and it's going to obstruct your airway. So a lot of patients do find that the airway can be affected by how you're sleeping in the pillow. The problem with that is it's all in good intention in the beginning of the night, but once you're asleep, you don't have control over how you're sleeping in terms of having that consistent through the night.
So now I've gone through the study, you've examined me, I have obstructive sleep apnea. What's the next step?
So we've done the sleep study and we've determined you have sleep apnea. So appropriately so, what's the next step for you as a patient? So I'll share this slide here. So observation, do nothing. We don't like to say do nothing in medicine, but there are some patients where it's perfectly appropriate to kind of watch them, see how they're doing. Those are patients who have mild sleep apnea that are not particularly symptomatic. They're young, healthy. They don't have any other medical issues such as poorly controlled diabetes, high blood pressure, asthma, other uncontrolled heart disease, lung disease, things like that. Vast majority of patients are coming to see you for a reason, so we're going to do something about it. And this is kind of like the decision tree of how invasive do you want to be. There are oral appliances, which are basically mouth guards that are made by dentists who can kind of help realign the airway. Good for kind of milder sleep apneas or, patients who may not want to wear a CPAP mask, which I'll get to. There are upper airway surgeries. So like you talked about those nasal strips. So we can improve people's nasal airways, which with a septoplasty, which is correcting a deviated septum. It may not help your sleep apnea number, but it can help improve your nasal airway. We can take people's tonsils out. We can do what's called a UPPP, which is basically kind of changing the shape and size and orientation of your palate to have it not collapse as much. Down to like very extreme options of what we call a tracheostomy. That's like a breathing tube through the neck. Those are like very extreme cases. We don't really do it, but there's a whole range of what can be done. The last option, which I put here, is CPAP, which is continuous positive airway pressure. That's that breathing machine that is what's put on your face at night, and it basically will deliver a pressurized breath every time you try to breathe, and basically prevents that airway from collapse. And this has kind of been the workhorse for sleep apnea for decades. It is the gold standard treatment. It is the first line treatment. When we say gold standard, we mean like that's what everyone should be tried on first in general.
Why?
Unless there's anything else glaringly obvious in terms of their exam. You're like, oh, this, your tonsils are giant and they're completely blocking your airway and they got to go. And in your opinion, you feel like, okay, that might be all you need. But in general, this is a vast majority, and this is kind of what's existed as the option before Inspire came about.
Why is it the first line for treatment?
It's proven effective when used. It has great results, and it's not invasive. It is not going It's not surgery. Anyone theoretically can use it. Um, and, that's anything that you generally try first with patients, you try to be as least invasive as possible.
Yes,
You
I
want to
understand that.
give them something that's, reversible. And if it fails, it fails, no bridges burned type of thing.
When I was doing a little bit of background to prepare for our talk, an interesting study I came across showed that 30% of patients don't consistently use CPAP after the first 3 months. Is
Yep,
that kind of what you see as well?
I do. And I think the degrees of success can vary based on how that CPAP is getting set up. I do find that sometimes if, patients see someone that doesn't manage CPAP routinely, with all good intentions, it gets ordered for the patient, but no one's really following up on it. How's it working? There's multiple different masks, there's different sizes, different fits, different orientations of how the tubing goes. There's
Right.
a lot of troubleshooting that goes on that can help a patient succeed with CPAP. And sometimes I do find that it goes a little bit to the wayside. There's a thing called a compliance report. So most of these machines are connected to Wi-Fi,
Yeah.
and over the course of 30 days to 3 months, it'll generate a report for the provider to say, hey, did the patient use it? How often did they use it? How many hours? Did their AHI number go down? It'll give us a real-time calculation. It'll tell us, is there a lot of leaks? What are the issues with the machine? It gives us a lot of data to say, hey, yeah, actually, you used it and it didn't work for you. Or this is when you stopped using it. It was like middle of the night. You probably ripped it off and,
Right.
didn't know that
Right.
you took it off.
Especially if you change positions all the time. It's like,
Exactly. So I think some of that adherence is maybe lack of follow-up or lack of, circling back with a patient about, hey, how did this work? It's not just like you have it's like a blood pressure medication or a cholesterol medication. Your primary
right.
is not going to put you on something and then never check your labs again, right? They want to make sure
Exactly.
it's working.
Of course.
So that's an important part of CPAP is that kind of closing the loop on it.
I like the way you phrased it. You're like, when it works and when it's used, it's like great and effective. But if you're not using it, it's not so effective. And there's multiple scenarios where maybe it might be challenging, if you're going
Right.
on a camping trip or it's like,
Right.
or you're going on whatever kind of trip. It might be a little tricky, or just if you're a
But
very
that's a good
restless
point, though. I
slipper.
tell patients it's okay if you don't use it for a week. Go on your trip. Go on your camping trip. Don't let this be a reason why you don't use it. This is a long-term problem, medical problem. This is not something that's cured and everything is undone because you didn't use it for a night or two. Because we still have to live our life. It's about the marathon, not the sprint.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
And we are back with Dr. Shah. We were just discussing, Doctor, some of the pros and cons of the CPAP. So now, if it's truly not working for you as a treatment option, what's the next step?
So this is why the Inspire came about, to kind of address that poor CPAP tolerance adherence, because if I think the number is high, and it might be higher than that 30%, that when you really kind of get down to it, there's so many patients that just aren't tolerating it. So short of the other surgical options of like tonsillectomy and palatal plasty and things like that, that's where the Inspire implant comes in. And the broad grouping of that is called an upper airway stimulation or a hypoglossal nerve stimulator. So
Okay.
basically how it works is we're finding the nerves that control the tongue movement.
Okay.
We wrap an electrode around the branches of the nerve that push the tongue out. We want to find the branches that push it in and the branches that push it out and kind of isolate that division point and make sure we find the ones specifically that help push your tongue out.
Okay.
Once we find those, we wrap an electrode around it. This is going to be up in the neck, right around here under the jawline. And then we kind of tunnel it through the neck all the way down into the chest.
Okay.
Now, in the chest, there's going to be a little device like a pacemaker device. And that's going to connect to the wire that's in the neck. And then we'll send another wire that goes to the surface of the lung. So as a closed circuit, the way that it works is when you go to sleep, it's going to be sensing your attempts at taking a breath. And then every time it senses that movement of your lungs starting to inflate, it's going to send an immediate signal up to the tongue to push it out of the mouth and open up the airway.
So can I back up for a minute? And I will tell our audience too, if you want to look at the apparatus that Dr. Shah is speaking about, go to the website inspiresleep.com. And it's like I said before, it's a really nice website, and they have a lot of little videos that you can look into, but they do show up close what the implant, exactly what it is that he's talking about. How big is the implant, doctor?
Yeah, so it's about I would say about 2 by 3 inches, and I can post some pictures up here.
Yeah.
If we can enable the share.
Yep. Jess is going to do that right now.
Right.
Perfect. Thank you.
All right. So let's. All right.
Oh, nice.
So basically, when you go to sleep, you get a little remote device that turns it on. You go to sleep, and there'll be a delay. So the delay we can set maybe 30 minutes, 45 minutes, an hour, and basically it's going to turn on after that time frame. So what it's going to look like is this little breathing sensor in the chest is going to send a signal up to that nerve right here where we wrap that electrode around this yellow nerve here, and it's going to push your tongue out every time you breathe.
That's amazing.
Open up the airway so that you can not have those obstructive events.
How long did it take to come up with that technology?
So this device was in development for over a decade or so. Around 2014, it got approval for implantation in patients. So we're kind of in that 10-year mark now that it's been available. But it was over a decade of investigation, development, and kind of different iterations since 2014 to today. We're now on the 5th generation of the implant.
Wow. So do you feel it? I know, but when you're sleeping, do you feel like when that's like stimulating the tongue to move forward again?
Yeah, that's a great question. So, you can see here, this is the back of someone's tongue. This is the airway they're breathing through. You see like intermittent glimpses of black.
Yeah.
That's what they're trying to breathe through. This is the epiglottis that closes your airway when you swallow. This is the back of the tongue. Sorry about that. So now you can imagine this is with the implant on. You see how much it's opening up? You can see now here, these are the vocal cords.
I want to breathe with that one.
I know. Me too.
Right.
This is the back of the nose. So this is the back of the nose here. This is the palate, the soft palate, which is the roof of your nose or roof of your mouth that separates your nose from your mouth. So someone with sleep apnea, it's completely closed off. Now with the implant on, you can see it's pulling that palate forward. So it's not just acting on the tongue, it's kind of acting on a couple levels in the airway. So to answer your question, after you have this implant in, we spend a good 3 months increasing those stimulation levels. It's like if you go to the gym and you haven't worked out for 5 years, you're not going to go pick up the 100-pound weight. You're going to start with 5 pounds
Yeah.
and you're gonna work your way up. Otherwise, that muscle is going to fatigue. Um, so in a similar way, we're going to start at very small, low levels, and the patient is actually going to have the remote. And just at home, once a week, they're just going to pump the volume up week by week. And then over 3 months, we get patients to their target. Every target is kind of different for each patient depending on how they're tolerating it. So we want to kind of land in a sweet spot where we're maximizing the stimulation and really opening up the airway, but not so much that patients are feeling it or feeling uncomfortable. So that's kind of that, we call it a titration time frame where we customize it.
Does your tongue hurt in the morning? I know that might be a silly question, but
Yeah, at first, some patients do say that, they can feel it even tracking kind of back up towards their ear. And it's like you're working out any other muscle in your body, it will take time and it needs to get acclimated. And most patients, if they tell us that beyond kind of that 3 month, then it might be that we're going to dial back on their stimulation. But most patients get through that kind of like soreness after the first month or two of getting stimulation kind of consistently through the night.
Dr. Shaw, I'm going to back up just for a minute to make sure I'm understanding everything. So, this is a treatment for obstructive sleep apnea. Obstructive sleep apnea, one of the things that can cause it is when your tongue kind of relaxes back and closes off that airway. But there are other causes for the obstructive sleep apnea too. So is the Inspire specific to this cause for the obstructive sleep apnea?
That is a great question. And I think that kind of segues nicely to um, patient eligibility. So, there are parameters like age, over 18, body mass index, so how much you weigh compared to weight to height ratio. There are certain parameters, we can't be putting these in this morbidly obese population because, weight is important, as we had already talked about. And then kind of what you just kind of alluded to was um, just obstructive sleep apnea can be caused by, or sleep apnea can be caused by a variety of processes, both the central and the obstructive. So we talked about central, meaning your brain's not telling you to breathe, and obstructive is you're trying to breathe, but your airway's blocked. So you can imagine the Inspire implant's only going to work for obstructive sleep apnea. So it needs to sense that initial attempt at breathing in order to fire. So if you have a large portion of central apneas, you can't get the implant because it's not worth putting something in you if it's not going to treat, you know, something that's happening more than 25% of the time. We just feel like it's not worth putting a permanent device in someone that, 30 plus or even 50% of the time it's not going to be firing. So that's where the central mixed apnea index comes in. So if you have less than 25% of the time where there's central or mixed apneas, you can still get the implant even if it's not an obstructive process.
Nice. I have a question regarding the BMI. So I just did a quick calculation because my brain doesn't work in kilograms. So with the BMI calculations for the 32, that looks like it's about 5 feet 4 inches, around 185, 190 pounds. Will that BMI ever increase for use? I know you were talking about not the morbid obesity, but that's,
Right.
that's my goal weight, for Christ's sakes.
Right. So it is insurance plan dependent. So if you look here, Medicare allows you to have a BMI of 35. If you look down here at the asterisks, the guidelines are changing. The FDA has approved the implant for a BMI up to 40
Nice.
and an AHI or sleep apnea severity up to 100.
Okay.
Whether, say you're a BMI 38 patient, that's going to be dependent on your health insurance plan, whether it's Blue Cross Blue Shield, Tufts, or Harvard Pilgrim. There's a million permutations for each plan about, what your candidacy is. I will say that I'm kind of in the camp of just because you can does not mean you should implant these in patients. There are plenty of patients that are candidates on paper that there's some amount of clinical decision making where you're like, I don't think that
Of
this is going to
course.
be appropriate for you. And that could be for a number of reasons. One is if your body mass index is 38, weight's going to be still a big contributor. And, I need to make sure that I'm not just putting a band-aid on the problem, because I think weight loss is still an important part and we need to work together on that to
Great.
lower it. And give a surgeon a scalpel, they'll cut you open, but it's my
There has
job
to be
is
some
also,
discretion. Yeah.
yeah, it's to make sure I'm doing the right thing for you. And a lot of times
Yes.
that's saying, hey, while you are a candidate for the implant, I still think you need to lose weight, because you could also lose the weight and not have sleep apnea at that
Right.
point. And
Right.
so then what did I do for you? And I could help a lot of downstream things by working with you on your weight. Um, Patients with insomnia do not do great with this implant. You can imagine, like you said, do patients feel it? Most patients do not. But if you are a very light sleeper, you have trouble falling asleep, or you have trouble maintaining sleep through the night, those patients tend to not like the implant because it's waking them up
Of
and it's
course.
keeping them up. So part of teasing it out is your trouble staying asleep your sleep apnea that's waking you up, or is it insomnia? And sometimes that's just a discussion with the patient. But like you said, there are patients that, even if they are a candidate from the weight standpoint, we gotta think critically about those to say, have you done everything you can? I have some patients who have done diet, exercise, they even had like bariatric surgeries, or they're on a GLP-1 like Wegovy or
Right.
Ozempic. Their weight has kind of stabilized and
Yep.
they're where they are, and that's where they've always been. Then those are ones that I feel, this is the right thing for you.
So again, just so our audience kind of has a clear idea on the population that this would work well in, the cutoff BMI for some insurances is probably a little bit less than 40. So again, that would be someone who's 5'4", now weighing around 240, or someone who's 5'10", weighing about 280.
Hmm.
And I really like the discretion that you use for this, because it is invasive, and you want it to work well. So you're looking for like
Right.
that candidate that has a really good percentage of this being effective treatment for them. So can we talk a little bit about the procedure itself? Like, what, I know you said it goes, you have like a little incision on your chin and a little
Yeah,
incision here, but I'm very sensitive to pain,
absolutely.
so talk me through this.
Yeah. It's like you already looked at my slides. These are all perfect segues. So, um, when we see a patient, oops, sorry, let me just share this here. Okay. Is
Oh,
that coming through okay?
yes, it is.
So when we see a patient, you said, like, what happens when I see you? So um, I see a patient, we screen them, we say, okay, you look like you're a good candidate for the implant. The next step is what's called the DICE. So the DICE is a drug-induced sleep endoscopy. That is an insurance requirement as well as a diagnostic requirement that says we got to put you to sleep for about 5 minutes under anesthesia, similar to a colonoscopy, and basically take a look with the camera in your nose to see how your airway is collapsing. And we want to make sure that the way your airway collapses is going to be improved by the implant. There's about 90% of patients are good candidates. That 10% subset are not good candidates based on their airway closure. And I'll kind of give you a crude example of what I mean is, the implant is pulling your tongue forward. So you can imagine if you collapse front to back like this, if I pull your airway forward, it's going to open it up.
Right.
If you collapse side to side like this, if
Oh,
I pull your tongue forward, it's going to pull it close.
yeah,
So we want to make sure we don't make patients worse, or we don't put something in that's not going to help.
exactly.
Uh, so if that looks good, then we get you all set up for your Inspire implant. You have the surgery, and then you just get activated like we talked about. So in terms of the surgery, there's two incisions. There's one here up in the neck, and then there's another one down here in the chest. And basically, this is how the whole system works. This is the device right here. It was built off of pacemaker technology. So it's very, very similar to a
Yep.
pacemaker like you would have for your heart. We always put it on the right side in case in the future you ever need a pacemaker. We're not in the way,
Smart.
and we leave that side open for anything that might need to be done in the future. So um, it's going to start here. There's this wire here that's going to the surface of the lung, and there's another wire here that's going to the neck. And basically, this is kind of what it looks like. Where this is up in the neck, this is the nerve, and there's a little silicone cuff that we're wrapping around the nerve here. And then in the chest here, this is a little sensor that we're putting right onto the surface of the lung. And that's how it works.
Can you see that? Like, does it cause like a little bump on the skin? Like
Yeah,
if
so this thing is not super low profile. It has to house a battery that lasts 10 to 11 years. It
okay,
has a lot of electrical components. So I would say it is about 3 millimeters in thickness.
okay,
Initially after surgery, you do feel a little bit of that kind of lump there. Over time, as things heal, you don't really feel it unless you like really kind of go around searching for it. Now,
okay,
certainly, like very thin patients, you will feel it. Patients with a little bit more fat under the skin, you may not see it or feel it at all. But I haven't had too many patients complain about it. And sometimes we adjust the location for certain patients depending on their life. I have some patients who are police officers who we've kind of adjusted the placement for their bulletproof vest.
yeah.
Patients that work up on electrical lines and wear a harness. People who are avid rifle shooters, we'll move it around so that things aren't in the way, and we can kind of customize it.
That's pretty in depth. I'm
Yeah.
impressed that you like look into all of that. So when it's like, so I've just had this procedure. It's in me now. When can I start using it?
So after surgery, we gotta let it heal for 1 month. So it's a pretty fast recovery in terms of immediately after. It's Tylenol, Motrin type of pain. I don't put patients on narcotic pain medications,
Okay.
and basically kind of get back to normal things within a few days. Um, once you've had your surgery, you wait about a month for everything to heal up. And basically, what we want to happen, and just going back a couple of slides, we want this cuff that's around the electrode to form a capsule, your body to kind of wall it off and basically create its own little glue that's holding it in place. Because as your tongue moves and gets activated, we don't want that to shift position because we spend a lot of time in surgery making sure it's perfect. So once that's all healed up, then you get activated a month later, um, and then that's when you start to increase your levels at home over the course of the 3 months.
What about going for an MRI? Is like, can you still go for an MRI if you need one?
Yeah, so MRIs can be safely performed.
Oh, okay, great.
When we get MRIs, they're varying degrees of strength of the magnet for an MRI, and they're measured in Teslas. The Inspire implant is rated up to 1.5 Tesla. So just you have to be careful about the strength of the magnet you're going to.
Okay.
So usually when you get surgery, you get a card that one gets you through the airport, and two, you
Oh,
can
that's
give to
right.
anyone that is getting you set up for an MRI, and they can look at it and it'll say, hey, make sure this magnet is less than a 1.5 Tesla, and you'll be fine.
Is there anything you're telling the patients not to do after they get this implanted?
Yeah, so we tell patients in general you can kind of get back to your normal lifestyle. Obviously, like super strenuous stuff. I have like some avid dirt bike racers, and I'm like, hey, if you fall off that dirt bike in a hard crash, like you could tear a wire.
Yeah.
So you have to be careful about that. Scuba divers cannot go below 100 feet, and
Oh,
that's like a hard stop. And some people who are avid scuba divers, like that is very important for them. Um, so we need to kind of make sure from that standpoint. Otherwise, for the most part, the vast majority of the population can get this and not have a significant hindrance on the things that they like to do.
So when you're having this procedure done, is this done locally? I mean, where are you doing this?
So we're doing that. You have to be asleep for it.
Okay.
One, it's not a comfortable thing that anyone would be able to tolerate doing it awake, but we need patients to be very still. We're working on the surface of the lung, less than a micron thick layer away from the lung surface.
Yeah.
So, we don't want to risk collapsing a lung. We're also, as we're finding those nerve branches for the tongue, we're teasing out very microscopic branches, and we're using a special nerve monitor that is going to show us, is this a branch that we want to keep in the cuff? Is it a branch that we can't? Because you don't want to be fighting those nerve branches where you're pushing and pulling, pushing, pulling. We want just the push ones. So we need to really be precise, and patients need to be asleep for that.
Now, suppose like in 10 years you've lost the weight and you feel like you're good. Is it hard to take out?
Yeah, so that's a great question. And we're just getting to that first round of battery replacements. I think the reason we have these BMI parameters in the first place is that it does give us a sense of where patients are with their weight and where they kind of have
Yeah.
always been. So we know that generally, hey, I've been stable at this weight for 5, 10 years, and I'm not going to be able to lose any more. That does help us kind of feel better about, putting something in. I give patients the analogy of like getting this thing out is, imagine you take a bucket and you fill it with cement and then you put some spaghetti in there and you ask me in 4 or 5 days, I want you to take that spaghetti out without breaking
Oh
a noodle.
man. Yeah.
That's really hard to do.
Yeah.
You can take it out, but your body, it's a foreign body. So your body is going to be making scar tissue around it. It's going to try to like wall it off from the rest of your body. That nerve, like we talked about, it's going to get a capsule around the cuff. So, your structures that are at risk are the lung, the nerve that controls your tongue movement, the nerve that controls the movement of your lower lip. All these structures are very close by. To go back in is challenging, very doable,
Yeah.
and can be removed. But, we want patients to know that, we're in this for the long haul if we're going to do this.
So tell us about the patients who've had this done and who've done really well. What have you seen?
So, yeah, actually,
Time.
I had a slide here. So in 2024, basically
Ooh.
10-year, they Inspire did a patient satisfaction report. And, the vast majority of patients are very happy with this. And I think, as long as you have a good team in terms of setting this up with pulmonary, having a team that's going to work on patients in terms of getting them to the sweet spot, they do really well. We need to make sure we're spending the time with them to get them in the right range, getting a follow-up sleep study and making sure that their sleep apnea is treated. But I have so many patients that feel like they're teenagers again. Their
Really?
quality of life is just so much better. They're sleeping better. They have the energy to do the things, whether it's simply just like getting up and going to work, or not feeling scared to drive. That has been really rewarding. Patients come in and they feel like, we're not curing cancer here, but we are changing people's lives because they just feel so much better. Like I have a patient who's a woodworker and he was like, I had so much energy. I completely redid my entire kitchen and built new cabinets.
Wow.
I have patients who are like, I'm up at 5 a.m. now because my sleep is just so restful that I'm not sleeping till 9 a.m. anymore. So it's, some patients, wasn't the sleep side of things, it was the headaches. And they're like, I've been trying the migraine route, all these migraine medications, but really it was a sleep apnea. Now they're not waking up with headaches that are lasting throughout the day. So it's been incredibly rewarding.
Dr. Shah, one of the things I've learned from doing this podcast for the last 3 years and talking to a lot of different specialists is sometimes you don't realize how good you're not feeling. You're used to the way you feel. And then all of a sudden, someone makes you feel like I'm just looking at these numbers for your satisfaction, 91%, 93%, 92%, 90%. That's life-changing on like a day-to-day basis.
Right.
And, you might think you feel fine till you have something like this done and you're like, oh my God, how could I have ever thought that was okay? You know?
Yeah, it's so easy to get complacent with your health and kind of just dealing with things as they come. Um,
Exactly.
yeah, absolutely.
Can that slide, I couldn't
Oh,
read
yes.
all this stuff next to those great numbers. Can you just give us what was a 91, 93, 92, and
Yeah, so
90%?
91% say how does Inspire compare to CPAP? 91% say it's better than CPAP.
Nice.
93% would recommend Inspire to a family or a friend. They would choose, and 92% would choose Inspire again if given the choice. And then
Nice.
just overall satisfaction, how satisfied are you? It's about 90% of patients.
You know what that shows too? It shows that you're really doing a great job with your screening. I mean, these are going into the appropriate patients, that are.
That's a really good point. Choosing the right patient is paramount to their success. And I go back to what I said before is just because you can doesn't mean you should. Because there's plenty of patients that fit the bill, and the more of these you do, the more experience you get, you can figure out that like, hey, I don't think that this is going to be great for you. And patients really do appreciate that, even though they're looking for a solution and they're like, I'm so done with the CPAP. I have plenty of patients that I've seen. I'm like, hey, I really think we got to work on the CPAP. And okay, fine, if we try it and you can't do it, I'll feel better about going ahead with this. But my guess is that we might want to do something else for you. And I that's also a very humbling thing that I've seen with patients is that they're coming to me for surgery and they're generally fine if I'm like, hey, we got to do something else other than this surgery. And maybe it's a no now, but it might not be a no later. And so, yeah, you're absolutely right. Patient selection is key.
Yeah, and I think I had read somewhere when I was doing the research that there might be a push to have this as a first line of defense instead of waiting for people to flunk CPAP, I guess.
Yeah.
So hopefully that isn't too far away, because I think there's a
Yeah,
lot of
I
people who
think,
can.
yeah, absolutely. But, I do think that for those small subset of people that do fine with the CPAP,
Yeah.
it's still a good thing to try because what if you don't like it? What if you're in that 10% of patients that end up not liking the implant? Um, and we never tried CPAP, I'd have trouble sleeping, no pun intended,
Exactly.
with that kind of patient that we didn't really try everything that we needed to.
Can I ask you a very specific question? So some of the patients that I deal with are kids that are very challenged, but I call them kids, but they might be in their early 20s.
Mhm.
And they have sleep apnea, but they might have like autism, cerebral
Yep.
palsy, Dravet syndrome, what have you. And they would never be able to keep a CPAP mask on.
Yep.
Now, for that population, do you ever see this being used with that type of population?
I do. And I think that's actually a great population to consider this in because once everything is kind of said and done and implanted and up and running, the maintenance is very low for that
Yes.
patient population. And I have done plenty of patients with on the spectrum, um, cerebral palsy as well, that, it's a great option for them. Patients who have like spastic CP, often sleep position is difficult. Um, just getting the mask on can be difficult.
Yes. And
Um,
the thing that's heartbreaking sometimes is they don't understand what you're doing to them.
right.
You're
And
like,
it's easy enough to just take something and go like that, and that's it.
yes, yeah,
The one of the original patient populations that were studied and approved for early on in Boston was at Children's was the Down syndrome population. So
yes.
certainly, yeah, it's not just your average, you know,
That's
60-year
great.
old healthy patient. There's a lot of applications for this.
Nice, nice. Well, I think we're kind of coming to our close, so I will ask you at this point if there's a message that you'd like to leave with our audience, or if there's any other points you want to hit on before we do our summary.
Yeah, I just want to thank you for having me on, and it's something that I never thought I was going to end up doing this as part of my surgical repertoire. But the more I've gotten into it, the more I've really enjoyed it and kind of enjoyed the outcomes. And one thing I've found is that patients, while you might be coming for an Inspire evaluation, we might tease out some other stuff that will work for you, whether it's the implant or not. So it's never a waste of time to get evaluated and kind of think about the options. And some patients, when they hear about what it entails, are like, you know what? I'm just going to go back to CPAP because, it wasn't as bad as I thought it was. And so I think it's never a waste to explore your options and kind of talk to somebody. And just kind of as a separate aside, I'm currently doing a study. I also teach up at Tufts School of Medicine, and we're doing a study on my last 2 years of patients and kind of the incidental findings that we've found on patients as part of their Inspire evaluation and workup. I found some cancers that we've treated and cured in patients.
Wow.
We've caught them early. We found benign lesions that we took out and it cured their sleep apnea. So I do feel strongly that patients who have sleep apnea should get evaluated by ENT to just at least have an upper airway evaluation and make sure there's nothing else going on that could be causing your
Absolutely.
sleep apnea. And that's something that I've learned. We always knew about it, but as I increased my sleep volume tremendously by doing the implant, I have just seen so many patients that I'm learning more about, the importance of that.
Nice. Dr. Shah, thank you so much. And if people want to get in touch with you or continue the conversation with you, how would they do that?
Absolutely. So probably the easiest way is to call my office for an appointment. And our information is right there. You can
Great.
also book an appointment directly through the Inspire website.
Nice.
They have a whole process where they can help you get an appointment and set you up for it. Feel free to talk to your primary care physician. Your primary care can always reach out to me directly, and we can get you in for an evaluation.
Nice. Thank you so much. So that concludes our episode. And in closing, I will say thank you for listening to our show. If you would like to become a sponsor, please contact us at 617-775-3737. Special thanks to Ron Gamache for our intro music, Primacare, your trusted medical providers in Southeastern New England, and BioSkills of the Northeast for producing our show and available to produce your show by calling 774-301-8811. Bay Coast Bank is just right for all your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Duncan Hearing Healthcare you can trust with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. Thank you.